All right, so let's start the second part of this chapter 8, emergency situation and complications of anesthesia. Now, we, as a surgical tech, when you are scrubbed and when you see there is an emergency situation, could be cardiac arrest, or it could be a malignant hypothermia, some side effects like that, or some situation where they need the crash cart. In that case, as a surgical tech, if you are scrubbed, your job would be to remain sterile, protect your sterile field, and wait for the surgeon's order. You have to stay calm and wait for surgeon's order and protect your field. If you're a circulator working that day as a circulator, nurse help, you're helping the nurse also. When you're going through this situation, you will hear for the order. Everybody self-designate themselves during the type of emergency situation. You will see anesthesia will say, okay, I'm going to provide medications. Nurse will say, okay, I'm going to go get the crash cart. Every time they do something, during the emergency situation, they will say out loud. Why? They're doing that to inform the other team staff in the room, to let them know what they're doing, so that nobody is duplicating their stuff. For example, if the circulating nurse says, I'm going to go get the crash cart, that means you don't have to also go get the crash cart. Then you know he or she is getting the crash cart, so you do something else. Then you say, okay, I'm going to, for example, maybe get the medicine for the anesthesia. Or you can say, I'm going to call the intercom for extra help, stuff like that. So everybody say out loud what they're doing, letting the other team member know, and so that they don't duplicate the stuff. When you are circulating, mostly your job would be to help the anesthesia, stay by the stand of the anesthesia. When they require suction, you provide the suction. When they require certain catheter, you open that catheter for them, or hold the mask on the nose, or whatever the anesthesia wants, you can do that help. Or you can decide to help the nurse by opening any sterile supplies that you need, by logging into the logbook, or by attending to the sterile field. When the nurse is busy with the crash cart, anesthesia is busy with the patient's airway, you can circulate the room to attend to the surgeon's need. If the surgeon says, okay, I'm going to close this patient up, so give me suture. And then you can open those suture. You can initiate the count process. You can get all the lap sponges together and help the scrub. So everybody divides their duty in the situation of emergency case. Now, anesthesia complication can happen. Patients are getting the anesthetic, they're foreign to their body. Some patients, they don't have history of anesthesia before. So these patients getting this foreign substance, and they may have allergic reactions that was not known before. So the allergic reaction that we see commonly in the anesthesia is called anaphylaxis reaction, exaggerated response of allergy, not just the simple allergy that you get from poison ivy or bee sting. These allergies reactions would be very rapid, and it is going to really go towards a life-threatening situation. These anaphylactic reactions can be, you can have it even though, you are not in the anesthesia, in the anesthetic, not taking the anesthetic drugs. Ingredients like latex product, rubber, certain synthetic material, tape that we use in the operating room, they can also produce a serious antigen antibody reaction. We call it anaphylactic shock. If you have history of allergic reaction, then it is very easy to handle that. It will be on your patient's chart that you have these list of allergy, and then we are going to exclude those allergic material from the operating room. If you are allergic to latex, we're not going to have latex product in the room. We will have non-latex product. If you're allergic to paper tape, we're not going to have paper tape. We'll give you silk tape. Things like that. If you're allergic to certain medications, we're not going to provide those medications. Certain product like shellfish, if you're allergic to, then we're not going to give you certain medications. So history of allergy can be prevented, but without having a history, when the patient responds to certain things with a serious allergic reaction, we get these: asystole, where we have cardiac arrest, absence of heartbeat. We get to give bolus amount of medications to be administered during this type of problem. If somebody is getting antihistamine, they need a lot of antihistamine to be given in bolus amount to fight this allergic reactions. Somebody may have bradycardia. We see the heartbeat is slow, less than 60 beats. Some patient may have bronchospasm, where their airway, the bronchi, trachea, could inflate so badly that breathing is not possible. Their blood, their airway constricts, and breathing, then it is called bronchospasm. They don't get the oxygen they need, and because of less oxygenation, their skin will turn blue, cyanosis, and their membrane, mucous membrane, will have less oxygen in the blood. Cyanosis will take place. Or if somebody is having just opposite of that, having diaphoresis or hyperhidrosis, they're profusely sweating, perspiration. when they're having medical emergency or shock, these people's body temperature spikes way above 105. And they may have this type of symptoms that we can see. We may see these patients are not breathing, dyspnea, or shortness of breath. And COPD patient, the patient who has chronic obstructed pulmonary disease, they may have this type of problem while they're getting the anesthetic. So temperature, when it goes up, we call it pyrexia, higher than 100 degrees Fahrenheit. When they have pyrexia, along with that, they may have rapid heart rate greater than 100 beats per minute, which would be tachycardia. They have allergic reactions on the skin, urticaria or hives. Immediately you see that all the skins are getting this type of patches. So complications of anesthesia could start with anaphylactic shock, and it could go towards a very, very bad lethal situation like loss of consciousness. They will stop breathing, the oxygenation is stopped, their heart will stop, and eventually their brain will stop also. If the early signs of anaphylactic reactions are caught and treatment starts. That is why anesthesia and nurse, mostly anesthesia, their job is to watch the patient closely. Every second they watch. They look for all these signs: hives, respiratory obstruction, dyspnea, labored breathing, circulation collapse like low blood pressure, or severe bronchospasms. When they see that, they will alert the team. They will tell the surgeon, stop, I got problem here. My patient is not breathing. Or they can say, my patient's having tachycardia. That's quite the opposite. My patient's having bradycardia. They'll say that, and the surgical team will stop, and they will wait. They will stand there. They will be standby. They'll wait for further instruction from the anesthesia. Anesthesia will get busy with the nurse to treat the condition of these type of complications like anaphylactic shock. The drug that may have caused the anaphylactic shock, they will stop that. They will give bolus amount of antihistamine like Benadryl, diphenhydramine, aminophylline for bronchospasm. They'll give those through IV. Only if the blood vessels are working, then those drugs are going to work. Otherwise, they have to do another way to solve that problem. If they see the allergic reactions coming from penicillin administration, codeine, contrast media administration, morphine, methadone or demerol administration, thiopental, or sodium pentothal administration, another drug called tubocurane in muscle relaxant administration. They'll stop these medications right away. They'll stop penicillin, codeine, any of these things that you're giving or the surgeon is giving. And transfusion reaction can happen. When the patient is getting blood, foreign blood, not their own blood, usually their own blood would not have transfusion, but if they're getting blood from the bank, that could cause transfusion problem and allergic reaction, serious allergic reaction. So that will be stopped right away. Will be given just liquid IV, like lactated ringers. Instead, if they're having airway problem, respiratory obstruction because of the bronchospasm, and bronchospasm, laryngospasm, or any type of chest trauma related inflammation has to be countered. These are the causes for respiratory obstruction. So the anesthesia will try to induce open up the airway by giving atropine, maybe trying to do some extra mechanical intubation to using the ventilator, or to provide more oxygen, give 100% oxygen to the patient. If the laryngospasm is happening this happens during extubation, when the surgery is done, and after general anesthesia is reversed, patient is waking up, and patient now throwing up fluids, blocking the tube, blocking their own airway because of the larynx mucosa secreting excessive fluid, and that fluid is coming out through the mouth, through the nose, blocking the airway. That needs to be suctioned out quickly. Excessive mucus fluid needs to be suctioned out quickly. And if they cannot breathe without that endotracheal tube, the anesthesia will put the tube back in. Maybe that patient requires that the endotracheal tube for a while until the patient wakes up properly. Every patient, they reacts differently to this extubation period. That is why the patients are told not to drink or eat anything before the surgery. NPO, no food or drink by mouth 12 hours before. If they have any fluid, coffee, tea, or juice, or they have pizza or something they have had before the surgery, not following the surgeon's instruction, they will have this problem. Vomiting, and that needs to be aspirated because the vomiting will block the airway, causing asphyxia. That means no oxygenation to the brain or other tissue there. The patient's gonna have non-oxygenated blood circulating. That needs to be reversed by suctioning, by aspiration, and patient requires to prevent this, patient requires alertness and patient requires to be told repeatedly about the importance of not having food before the surgery. Sometimes the patient may have electrolyte and fluid imbalance, maybe excessive blood loss, cause volume problem of their body fluid. That needs to be restored. So worst situation could be an emergency situation like cardiac arrest. That could happen for no reason. This because the patient is elderly, maybe age-related problem, and surgery. No matter what surgery it is, surgical procedure is a shock to the body, and that heart may just fail to take the shock, and the patient may just simply coding, means having a cardiac arrest. During this time, cardiac arrest or respiratory arrest, surgery use a term called code blue or code 99. Code blue is available most of the places. When that happens, what we do, what we have to do. If you are a surgical tech circulating the room, you have to call the code button. You have to press that code button to let the main front desk know this room. If you are in room 9, the room 9 patient is coding. What is the importance of code button? Immediately there is people who are standby for this type of emergency situation. We usually have anesthesia person standby, floating around, nurse floating around, extra surgical tech floating around to prevent this type of problem in the operating room. Those people will be activated. They will hear overhead announcement, code blue in room 9. All of these people who are standby, they will run to the room now. Extra anesthesiologist will help the anesthesia. Extra nurse will help the nurse. Extra surgical tech will be there in the room to help. If you are surgical tech, you did that code button, then your job would be to go get that crash cart. Then you can assist the anesthesia, wait for their order. If they require chest compression or CPR done to the patient, if they ask you to do that, only if the surgeon and the anesthesia ask you, like they will have to order you, go do CPR, then you can do the CPR until the help comes. And if you are in a scrub situation, which most of the time you would be, then you remain sterile. Assist the surgeon. They'll close the wound as quickly as possible. Help the surgeon close the wound. If the surgeon wants to use a sterile internal defibrillator to shock the heart, help them with the internal defibrillator paddle. If the surgeon requires open heart massage, help them to prepare for that. So you have job that you can do and prevent contamination of your surgical field. If you are a second surgical tech who is also scrubbed for that case, you may break scrub to do the runaround, to get the crash cart, to do the log book, write the log book. You have to maintain record for this emergency situation, so you can do that. So divide the job, assign yourself a job and do that. During this situation of cardiac arrest, the drugs frequently we see the anesthesia uses atropine sulfate. Atropine sulfate is a drug, cholinergic antagonist. This will have a direct effect on the vagus nerve. This will constrict the mucus and the membrane of the mucous membrane inside our airway and stop that over mucus secretion and keep the airway open. Atropine sulfate helps the airway to open. Cholinergic means it is a neurotransmitter that works on the acetylcholine which is a common neurotransmitter. Because of that, mucous membrane secretes mucus, and this atropine sulfate will block that acetylcholine and help the airway maintain open passage. When the airway opens up, the anesthesia then can give oxygen, 100% oxygen, and that will induce, stop or prevent further arresting the cardiac process. And they can also give additional drug like glycopyrrolate, Robinol, same as atropine. Atropine is a product, is a sulfate that is the only drug that you can put inside the endotracheal tube. You don't have to give IV. You can directly put it in the airway. They're available in a bottle and a tubing attached to it, sprayer. Anesthesia can take that bottle and spray inside the airway, inside the endotracheal tube. No other drug can directly go into the mucous membrane like that. They have to go through blood vessels. So atropine is a drug of choice for cardiac arrest. Then you can use Robinol, a epinephrine hydrochloride, which is adrenaline, a hormone that can be given by the anesthesia, also by the surgeon, cardiac stimulant. It can be given for allergic reactions also. If surgeon decides to push epinephrine hydrochloride or adrenaline, they'll ask the surgical technologist to get it on the field. So you receive it on your back table in a syringe, and you need a long spinal needle to inject into the heart muscle. So epinephrine hydrochloride. Anesthesia can give sodium bicarbonate. When the cardiac arrest takes place, body becomes acidic. That is called metabolic acidosis. So that needs to be treated with sodium bicarbonate, alkaline product, calcium chloride to restore the electrolyte function, digoxin or lanoxin to have a forcible myocardial contraction. Drugs like isoproterenol hydrochloride, isoprolol, the myocardial contraction and the rate will increase so that more oxygen will reach the muscles of the heart. Lidocaine hydrochloride is normally used as a local anesthetic, but it has another effect, very, very strong effect to treat ventricular arrhythmias. When the heart rhythm is all gone and you have a heart firing irregularly, electric activity of the heart is gone totally wrong. Lidocaine stabilizes that electrical activity, the rhythms. Norepinephrine bitrate, levopen is a very potent drug, helps blood pressure to go up. It's a vasoconstrictor. Blood vessels will constrict and the blood pressure will go up. Verapamil hydrochloride, isoptin, also can be treated as the for dysrhythmias. So these drugs can be used for cardiac arrest, and anesthesia will have all of them on their cabinet there. So all you have to do, they will ask for these drugs. All you have to do is just open them for them. They will do the rest. They will use it They know how to use it. They'll do the rest. Your job would be to open it for them. Check the level, check the expiration date, and give it to them. If you are assisting or you're working as a circulator, but if you're working as a team, surgical team, then you wait for this drug administration. Malignant hypothermia is a serious anaphylactic shock that happens to few patients because they are allergic to anesthetics, some anesthetics, not all of them, some anesthetics like succinylcholine, anectine. Inhalation agents like nitrous oxide. Now, malignant hypothermia is a condition when they have allergic reactions and their body will have these signs. Temperature of the body will really go up to a morbid level, really life-threatening level. The patient you will see is having tachycardia, tachypnea. The cheek muscle, the masseter muscle, that's a very specific symptom, will get rigid. The muscle will get rigid. Blood pressure will go all over the place, unstable blood pressure. Heart rate will not have a rhythm, arrhythmia, and the patient will turn seriously blue, cyanosis, profusely sweating, diaphoresis, pyrexia, which is the temperature will go up. Malignant hyperthermia. This hyper means above. Thermia is normal temperature of the body. Hyper means above normal temperature. And malignant hyperthermia, this term is a term associated with this type of problem, allergic reactions to the nitrous oxide or succinylcholine. We have a malignant hypothermia card. Each hospital has multiple malignant hypothermia card. These cards are color-coded, blue in color. They have, at the bottom part of the card, that's a freezer box. In that freezer box, they have ice and ice sludge, stereo ice sludge. Your job would be to open those, bring that card in, open that ice sludge, give it to the surgeon. So surgeon can pack the wound with ice, and also the nurse can put those ice around the patient's groin, thigh, armpit, neck, wherever they can find. They will pack the patient with ice. Ice will lower the body temperature right away. And anesthesia will hyperventilate with 100% oxygen to get rid of the toxin, carbon dioxide from the blood. And the drug of choice for malignant hypothermia is dantrolene sodium, Dantrium. That will relax all the muscle which are getting rigid. They will drop dantrolene on a syringe. Sometimes these malignant hypothermia card has pre-drawn syringes with dantrolene sodium on the top card, top drawer. They will use that. Nurse will inject sodium bicarbonate into the IV. Together, they will, as a team, they will manage the temperature using the ice pack, ice lavage, and nurse will give diuretics, mannitol or Lasix. All of these within few seconds will counter the hyperallergic reactions of malignant hypothermia. Today, we are all very well prepared for malignant hypothermia problem. although it happens once in 1,000 patients, not very often, we are prepared. We don't even lose that 1 in 1,000 patient these days because we are prepared. We have a card, we know the medications, we know what to do. And this is how the emergency situations, complications during the anesthesia can be handled efficiently, very effectively, and bring the patient back to life. So this is a chapter deals with two major problems in the operating room: bleeding and complications of anesthesia. So learn them, go over these slides. You have to memorize this terminology, and the medications that you have to memorize them. So when the situation comes, you will be prepared. You will be prepared in both roles. So along with the team member, you are prepared to counter any of these complications. All right. So now let me ask you that, do you have any question that comes to your mind at this time? I know this is a little complicated.
No, I don't have any questions right now.
Okay, please study this and know what you have to do under these conditions. Anybody else? Okay, let's see chat. Louis said no question. Okay, Mitzi, do you have any question? No question at this time. All right, Tori, no question at this time. Okay. In that case, I will open up another subject matter.